Well, it's a pleasure to be here. My voice hopefully will hold up for you all. And the topic for this section that the two of us are going to present is loosely organized around the evolution of pain medicine. So I would ask you all to think about this in terms of treating pain, evaluating and treating pain, not the specialty of pain management necessarily. As you heard earlier, in the specialty of pain management or pain medicine, concepts of integrated interdisciplinary behavioral medical care have been there for 40 years in little tiny pockets after they disappeared in the 90s due to changes in funding. A few places still do that. That's my background. After starting in sports medicine and orthopedic surgery, I actually really switched gears here. But the concepts of interdisciplinary integrated behavioral care, they've been there, but not in the main, not in the primary care clinics, and not in the majority of pain clinics, that's for sure. So I'm going to trace the evolution of pain evaluation care in this country, and actually around the world, it mirrors us, through the lens of what pain is, of the concept of what we're treating. Because that, in fact, has evolved to the point that the new concepts will have a tremendous impact on the things that we're discussing today, on the opioid crisis, on people who are overdosing on prescription and street opioids. While people are sitting down, are we okay in the back? Do I need to get closer to the mic, or is it just more annoying if I do? Closer? Okay, how's that? Better? I'll stay put. So I'm going to take you through a somewhat artificial a series of concepts that actually did dictate our thinking about how we took care of people, including how we prescribed and what we prescribed. So that is relevant. I'm going to tell you that there are 4 paths to pain. And this is not something you'll find in a textbook, but I'm going to tell you that, for thousands of years, we have conceived of pain for the most part as what a neuroscientist would call nociceptive pain. You stub your toe, it fires a little receptor in your toe, triggers the nervous system to communicate to your brain an ouch message. That's nociceptive pain. And that is, by and large, where the concept of what pain is starts and stops in the majority of our healthcare providing communities in this country, which is part of the problem that we're facing, has created part of the problem. From 1980 to 2000, I would call that the age of neuropathic pain. In other words, we started to understand through basic science research what diabetic neuropathy was, what postherpetic neuralgia is, what phantom limb pain is, trigeminal neuralgia, other conditions, complex regional pain syndrome. We started to understand that damage to nerves creates a very special kind of pain. Physical damage to the nervous system, whether it's metabolic or traumatic. And I'm going to just say from 2000 to now, and I'm tracing that based on tracking the discussion amongst my neuroscience colleagues. Because as you heard earlier, people like Fordyce 40, 50 years ago were talking about this. But at neuroscience meetings around 2000, a whole different conversation started coming up. People started talking about neuropathic pain that results from experiences, things we experience in life. No physical trauma to ourselves. So watching someone fall off a building in 9/11, that's an experience that changes our nervous system, whether you knew that or not, it is. That is now front and center amongst my neuroscience colleagues. Very little research so far yet because we don't have the models, the research models to study it, and we don't have the diagnostic criteria to talk about what I just told you. So that's the new frontier. Now I said there's 4, so I'm going to throw in emotional pain. Grief, loss, those sort of things are painful. We know that when we image the brain of a person who's experiencing acute grief, social rejection, that sort of thing, that the pathways that are active, the neural circuits that are working, are the same ones that if they were physically just acutely injured. So emotional pain is real pain as well. And I threw in secondary gain. That's saying I have pain to get out of work or school or something like that. That's not really a path to pain. So a couple slides on the, to kind of demonstrate what I'm talking about. This is René Descartes talking about nociceptive pain. Burn the foot, communication to the brain. The process involves transduction of pain, transmission through the nervous system. The spinal cord and the nervous system actually has a lot to say about what gets to our brain. It's kind of like the cell phones. The cell phone towers are what transmit the signal from your phone to somebody else's. That's how our nervous system is working. So I'm kind of talking to you about a three-part system. Input from the nociceptor saying something hurt, transmission, and then the brain receives a message. That's an important way to think about pain because it sets us up for the discussion of emotional pain and so on. So there's a pain stimulus. There is sensory processing of pain and emotional processing of pain. And that results in pain and disability. And these are some examples of the conditions that are out there. And again, this is probably where 95% of healthcare providers start and stop in their concept of what pain is, which you'll see is totally inadequate to treating pain and has actually led us, one of the reasons, aside from our colleagues in the pharmaceutical industry that you heard about, one of the reasons we were vulnerable. We, the healthcare system, were very vulnerable to doing the wrong thing, being led astray because this is what we thought pain was. And this is not adequate. Neuropathic pain can be conceived of this way. Take the transduction out of it. There's no pain stimulus, no noxious stimulus is what we call it. There's simply pain coming from somewhere in the nervous system. So think phantom limb pain. If there's no foot, how can the foot hurt? That's the signal the brain's receiving, foot pain. There's no leg even. Well, that pain is coming from somewhere in the nervous system. That's the basic concept behind neuropathic pain. And that has been a focus of research and teaching for the last 20 years. It looks kind of like this. Take that painful stimulus out. Now, the reason I'm showing you some of this detail is to show you this. Notice where we're talking about sensory processing of painful stimuli in the nervous system. That's the transmission towers in the cell system. When you damage the nervous system, something happens to change the way the nervous system processes pain. This is a key concept that we started to understand in the evolution of pain medicine and understanding and treating pain, is that there are actually changes in the nervous system that can become permanent in response to a nerve injury. We in the pain medicine field know that those don't become permanent for several months, and you can actually reverse things if you can catch this early. That's that sort of thing. So this slide is talking about a physical injury to the nervous system, which has induced changes in the way the nervous system processes pain. Key point. And that can be something that goes on for the rest of your life, unfortunately. Diabetic neuropathy can be for life, right? You can have burning, numb feet for the rest of your life because of metabolic damage to the nerves, to the nervous system. That changes the way the nervous system works. One of the weird things about neuropathic pain is that one of the hallmarks of it is non-painful things are painful. Just light touch can be exquisitely painful if you've ever seen a person with it. And for many years, that was sort of written off as somaticization, craziness. It's not. We can induce that same phenomenon in laboratory animals with nerve injury models. So these are some of the examples of neuropathic pain. So this is the second type of pain, neuropathic pain from physical nerve injury. In about 2014, moving on to the next type of pain, in about 2014, the International Association for the Study of Pain redefined what pain is for us And they said some kind of amazing things. They said people can report pain in the absence of tissue damage or any physical thing going on. They said usually this happens for psychological reasons. So they started to bring up this idea of pain for psychological reasons. It's a terrible sentence because it makes most Americans think they're saying it to my head and very defensive right off the bat. So, but that's what we got. We can call it a lot of other things, but this was put out there by one of the preeminent societies that defines for us what pain is. Now, what they're talking about is neuropathic pain from an experience that injures the nervous system. Now, that might sound a little weird, but you know, we've come to understand that experiences do change our nervous systems. That's what PTSD is. That's a change in structure and function, gene expression, and so on, all the way down to the gene level. So this is a diagram of nociceptive pain. Change it now to reflect experiential damage to the nervous system, I hope. Now, what I'm saying here is that experiences, just like injury to the nervous system, just like an amputation, can apparently alter the way our nervous system processes sensory stimuli. And it can happen with no physical injury. So what you see is something more like this. This is as accurate as I could get it. A traumatic experience. Oftentimes these are during childhood for a variety of reasons. Trauma is most effective at reorganizing the nervous system when the trauma sufferer, victim, is also helpless, and that by definition is a child. During childhood, the nervous system is forming, but also they are by definition helpless if they are perpetrated on by grown-ups who are 5 times their size and weight. This is very common in the military with military trauma. The most traumatizing events tend to be those that happen to your buddies when you couldn't do anything about it, that element of helplessness. So what I'm talking about here is a traumatic experience changes the way the nervous system works over here. I don't know if that, yep, changes the way the nervous system works and leads the nervous system to report pain signals to the brain. Those are real pain signals, and the brain is receiving the message, pain, just as if the tissues were injured. So here's a concept then that comes during the evolution of thinking about what pain is, that is driving the evolution of evaluation of pain, evaluation and treatment of pain. The developmentally reorganized nervous system. It's a tree. And trauma damages the roots. Now the fruit of that tree, let's do it nice and slow. Give my voice a rest. The fruit of that tree are many things. The ACE study from the 1980s from Kaiser Permanente, now taken over by the CDC, has linked developmental trauma to resistant obesity, insomnia, anxiety, depression, addiction disorders. Now this is sort of linking things differently. We're not talking about co-occurring problems. We're talking about root cause leading to problems. Short lifespan. A high dose of childhood trauma shortens the lifespan by 20 years. It's lethal. Trauma kills people. And we put in here neuropathic pain type 2. Pain for psychological reasons is another thing that we will see. So this is the constellation of symptoms and consequences we will often see in people who've experienced trauma in their lives to one degree or another. Fibromyalgia, pain all over the body, sensitivity, neuropathic pain, hallmarks, hyperalgesia, hyperesthesia, allodynia sometimes. Yet there's nothing wrong with the tissues in fibromyalgia. Research, biopsies, et cetera, has shown over and over again that there is nothing wrong with the tissues. The nervous system has gone off the reservation and is reporting pain to the brain. And usually because of some traumatic injury. Although research into that hasn't shown 100% of fibromyalgia sufferers have a history of trauma, I think that has to do more with the research than it does with the reality, but that's just my opinion. It's often described as cruel, punishing, horrible, and so on. They're hallmarks of this type of pain that you can pick up in a primary care office very, very quickly. 3 forms, by asking 3 sets of questions. These are the types of things these people will say. Nothing works for my pain besides medications with psychotropic properties, including opioids. Diffuse pain with no clinical cause evident, multiple somatic pain complaints, a lot of disability. These are the, quote, difficult pain patients that our primary care students in the ECHO pain program present to us. As a matter of fact, it was the ECHO pain program that really set me off on looking into this more deeply, because we noticed that about half the presentations in pain echo over the last 5 years have been this type of pain, have been traumatized people who had pain all over and no one knew what to do with them because actually they didn't have the diagnosis. They were trying to treat this type of pain as if it was nociceptive pain. You can see how difficult that would seem. You keep looking for the source of pain and you can't find it. So, I won't go into that. Emotional pain is also worth mentioning, and I talked about that. Pain can occur for psychological reasons. This is one of my poster childs. This is a woman who was a teacher in Tucson who came into the office saying, I have pain all over. This was her pain diagram. Some emotionally charged words in there. She says, my legs hurt so bad it scares me. She actually wrote that spontaneously. So when I was working her up, I asked, well, when did this start? 3-4 years ago? She'd had a mega workup for it, had been diagnosed with multiple sclerosis, had that taken away. Had been diagnosed with Lyme disease, had that taken away. Had been diagnosed with rheumatoid arthritis, had that taken away. When I say taken away, you know, the 3rd or 4th specialist couldn't confirm it. She was left she's a basket case, as was her family. She really had no significant mental health history, addiction history, nothing. She was on about 400 or 500 milligram equivalents of morphine a day and not functioning because that's what was done at the time. At the end of an hour talking to her and her husband, I kept saying, well, you know, what was going on? Were you sick? Were you in an accident? They were leaving the room and the husband stopped. He's walking out. And he turns around and he says, you know, this started about a month after that time that you were at the market and you were abducted and held hostage and the sheriffs had to shoot the guy from behind you. I'm not kidding, that's her. So the treatment was not medication. The treatment was not psychotherapy really. It was straight up trauma treatment like we might treat anyone with PTSD. She had not had PTSD diagnosed. She was having nightmares 3 years later and when I saw her, which got better with treatment that night. So that is how big the hole is in our healthcare system that these people drive through. So in defining pain, I'm going to loop back to that last part and kind of wrap it up because I don't have the endurance today. Pain is an experience produced by any combination of these. Nociceptive pain, now you know what that is. Neuropathic pain from a nerve injury. Or neuropathic pain from an experience that damages the nervous system, or emotions, or all 3. So it's interpreted in the context of emotional state, past experience. Then it gets kind of complicated, right? When the brain starts processing it. When people are having chest pain and their spouse has recently died of heart attack, it's a different thing. And it all leads to their behaviors. So the kind of the modern concept of what pain is that would drive our evaluation and treatment and is extraordinarily relevant to what we're talking about here is we see people with pain who have a chronic painful illness or injury. They may be depressed as a result from losing time at work with their family or not sleeping. There can be a lot going on. It can be, that's the nociceptive and neuropathic nerve injury folks. Predominantly, the pain is driving their distress. We can see people with pain who have had trauma. Think of that gal that I was talking about. You can't categorize her as number one. Not even close. She had absolutely nothing physically wrong with her body, with her tissues. With her nervous system, she did. These people have what I called here experiential neuropathic pain. And they may be open to actually treating the trauma that is changed their nervous system. There's another group, though, that doesn't want to treat the trauma. They want you to treat their back pain, their fibromyalgia, their abdominal pain. And if you suggest that it could be coming from their nervous system, they'll back off and they'll say, no, 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 no. Don't tell me it's in my head. I have a medical condition. That's a sort of a uniquely Western way of thinking about health. No concept of mind-body. And if it's in my mind, I'm weak. So we're up against that. We see patient after patient after patient that falls into that category. Because they persist with it's in my back pain, how do you think they've been treated the last 20 years against the backdrop of what we heard about marketing opioids? I would say, well, I'll tell you that the statistics on trauma will say that there's 20 to 30 million Americans that are severely traumatized in their histories. 20 to 30 million. It's about 15% of our population. How many of them do you think have come to the doctor and been placed on opioids to treat their pain? A lot. Do we know? No, we don't, and that is completely unacceptable. To this discussion, it is completely unacceptable that we don't know how many of these people are out there. Now, we started seeing a phenomenon, now and then we'd see a person have an overdose in our clinic, and, these people were number 3 type here, or maybe number 2. And we'd have them evaluated by the addiction folks, and they'd say, you know what, this is not an addict. That led me to talk to medical examiners. It led me to start talking to emergency room physicians and directors of OTPs, opioid treatment programs, residential and otherwise. And I started to discover a common pattern. The people are saying, there are a lot of people out there who I can't really label with an opioid use disorder. I can't say that. I don't think they're an addict, but they did have an overdose. So here's something for this group to consider. This is not in opposition to everything we've heard. This is it's an add-on. Here's something to consider. It is possible, I'm going to make the extreme case, it is possible, and the fact that we don't know is unacceptable, that the majority of people who have died of overdoses are not addicts. It is possible. We don't know. I would guess probably not, but I don't know. I can't tell you that. It is possible that those are people who have been put on opioids, realize that those are effective psychotropic medications, particularly oxycodone products, really good for anxiety. There's plenty of rat data. I can show anyone who wants to challenge me on this that oxycodone is excellent for anxiety. They've been put on those medications. They like them. The prescribing provider thinks they're doing a good thing, but the patient is really using an opioid as a psychotropic. If you don't believe me, why are they on benzodiazepines? Isn't that the most common combination? They're on other anxiolytic medications and muscle relaxants like carisoprodol that have anxiolytic properties. We don't know. That's the problem. And it actually does matter, because in my recent detour into the addiction medicine world, the treatment of somebody who has PTSD and pain due to changes in the nervous system from trauma has type 2 or 3 there, or maybe type 4 with a family situation that perpetuates, which is very common, very common. The family makes things worse. So we don't know how many of those people are using the opioid to treat without even knowing it, to treat their trauma. Those people are at high risk too. Those people are impulsive. When they're stressed, they will drink, they'll take more medication, and they will be at risk for overdose. They need to be treated. They should not be on those medications. We shouldn't have started them, but we did. So based on, to kind of make I wanted to make this tour through the evolution of thinking about what of pain medicine and our concept of what pain is relevant to this discussion. It kind of sheds some light on the possibility that we may have two populations: our patients with opioid use disorder and our patients with trauma. They do overlap quite a bit, but there's probably plenty of people with trauma who need a somewhat different set of resources out there for treating their trauma. 12-step program, I am told, it's not my area of expertise, but I've been told by over 50 experts already, so I'll take their word for it. 12-step programs are not appropriate, and they won't follow through with those. And I'm starting to see those dropouts actually in the practice I'm in now, saying that wasn't right. I need something different. So trauma treatment would be different, close to, but different from addiction treatment. So I wanted to kind of tack that on to the end of this discussion, that as we talk about the opioid crisis, we might not be so quick to say it's all about addiction. There may be two populations out there, and that's something we should be considering. I think I'll stop. Thanks very much.